All right. And the reason, so I introduced, Matt knows this. Cindy, you're new to this. Deb took advantage early to get started with me on the assessment or the certification, the training. And part of that aspect of the training was going through the online course, going through all the material, and then passing the CETS one portion, which is a question and answer, multiple choice, true, false kind of questioning. And then the CTS2 was to take it to the next level and really understand how to do an assessment, how to build a corrective exercise program based on the parameters that we highlighted in the course. And that's where Deb's at now. Deb and I have a couple of conversations because I require people to take to provide 2 case studies that we review. And what happens is they submit their results to me from the assessment they learned, and then we review it. And I look at the pictures, we watch the videos, and I correct or agree with what they saw, so that we're starting to see things identically, right? And so opening that up to, I'm gonna let someone else in right now. And that's kind of what Deb and I are doing now. Deb and I spent 2 calls on her husband, which is her first case study, reviewing his assessment, reviewing his protocols and things that Deb and I were talking about. And it was pretty enlightening, right, Deb? We got a lot of information out of that. Yeah. You can unmute yourself, Deb.
Yeah.
There you go. Okay. And I thought this would be a great opportunity for us to do this again because Deb has got some background understanding. I was going to take just a random person, but it was going to be challenging because someone else that doesn't know the ACM assessment wouldn't be able to perform it with them and get the details we need. So Deb's already got some background with it. We're going to go through the assessment. I'm going to share my screen. We're going to go through Deb's just as if she was a client. Let's see, I'll share this screen. This is the software screen, and this is one thing I'll share with you guys. My software is not like PTX. All it is an assessment software. It's not really even necessary. Deb, actually, you guys can all see my screen. It says the assessment things. Yes?
Yes.
Okay, someone else joined us. I'm not sure who that was. It was the 303 number, but welcome if you can hear us.
Hey, I can hear you guys. This is Stacia.
Oh, hey, Stacia, great to see you here. This is the sheet that Deb filled out for the assessment that we're going to go through on the software, and that's all the software is. It's a way to fill in an assessment, and it automatically kind of populates for you. It doesn't give you exercise, or it doesn't give you a way to build an exercise program because that's not PTX is a whole other animal, and that's very expensive to do. So I think, give John credit for putting that together. But this is more or less a way to capture it. But I just wanted to show you because this all looks like jibber jabber. Not to Deb's defense, it's not she jibber jabber, but it just looks a lot of numbers and different things. But we're going to look at what this means on the actual assessment form. That way, it's easy for you guys to see it, and then you'll understand how we look at this stuff. So, Deb, can we go through your initial assessment? We'll start with the static posture. I'll stop sharing and you can share your screen. Can we do that?
Yeah, you let's see.
I just let you share if you want to. Oh, Zena's on. Let me enter her. Add her. Hey, Zena. Hi, Zena.
Hey.
We just got started, and so Deb's going to we're going to start this assessment, and we'll share as we go along what this all looks like. So, Deb, are you going to share?
Yeah, I did. You don't see it?
Well, I don't know. Yeah, okay. So this is Deb's postural assessment because this is, I think, what you guys are very familiar with, taking a postural assessment. And from this, I wanted Deb to kind of, because this is part of her CTS2, part of our assessment protocol is to take a snapshot of a static posture and identify some areas that you look as concerning. And I think from what Deb has here, I mean, Deb, you can explain because you were the one this is your case study. So I want you to kind of tell us what you're seeing with this client or, for instance, yourself, and then we can discuss it further. But your concerns are what?
Well, my concerns, meaning my issues,
yeah,
not my posture. Okay, my actual frustrating issues had been neck discomfort. It's been it's gone from a lot of neck pain over the years too. Now just discomfort. Over a year ago, I had a really bad case of shingles, and that screwed up my balance really bad. So I've been rehabilitating from that. But I'm also my nervous system is still really out of whack. So I'm
Yeah.
kind of I'm just one of the I'm kind of a little bit of a mess and trying to rehab myself from that.
Yeah.
So mainly neck discomfort, periodic right wrist pain and weakness. Not often, but I get that sometimes. And mainly balance issues, and also since the shingles, my my feet and ankles and calves are really tight, and they didn't used to be that way like over a year ago. There's a lot of tightness and stiffness, especially in the mornings, and it does improve a lot when I move and do stuff. So
Yeah.
that's my main issues as far as my posture goes.
Okay.
Obvious right forward rotation, especially at the right femur, from like the right femur, right ankle. When I started this, my right ankle looked like it was gonna like snap. So it's better than when I started many years ago. But it's still weak, my right ankle. And like I said, right femur rotation, left valgus. I know they're both internally rotated and valgus, but the bigger thing is the right one's more internal, the left's more valgus. And you'll see that kind of at play in the assessments, which is cool.
Okay.
My pelvis tends to be left side, slightly posterior, and which really showed up actually interestingly in the ankle assessment. I don't have the pictures there, and that was the first time I did it. My pelvis went under when I tried to do the left ankle.
Okay.
And my right side tends to be right around neutral to slightly anterior. So there's always that like right a little bit forward, left a little bit under or posterior. Scapular disparity all up and down the body, basically.
Yeah, you got asymmetry, a lot of asymmetry.
Yeah. That's that's always been a battle, but not just that, but also being back on the line, I've been more and I'm often right forward rotated. Like that's been.
And you're right-handed?
I am.
So from what we see in your static posture, what's our approach? What was your approach before you met me? Or thought process?
Tried to get lots of people to help me. Try to help myself. Some things help, but nothing ever seemed to really get me where I wanted to be.
So what I'll share with you, one of the biggest things that jumps out to me in these pictures, we see all the asymmetries, the elevated shoulder, the rotation. We see the valgus in the knees. Yeah, I'd argue whether it's hard to see here, whether I can't tell because the green lines are on it, whether one's more medial and one's more valgus. You know your body better than I do. Oh, yeah, there you go. Yeah. So, okay, that's really cool. Even better. But one of the things that jumps out, you've got quite a bit of rotation there, don't you? Yeah. One of the things that jumps out to me is the compensation. And that's evident in your arm position from your right shoulder and your left shoulder down, your arm. And if you had a short sleeve shirt on, we would see your cubital fossa, the front of your elbow, or I'm sorry, the bicep, where the bicep tendon attaches. We call it the cubital fossa.
Here.
We would see that facing us, but your hands are pronated, because we don't walk with our hands out. Anatomical position is what we are able to name body positions and body parts through, so that everyone, wherever we are, knows what it means, right? The anatomical position is with you standing like this and your palms facing towards us, right? The dorsum of your palms facing us. But that's not the functional position of the arm. functional position of the arm is the hands to the side, so that thumb is pointing at us, right? And so that's one of the big things that's standing out to me right here is where your compensation is. And it's all in the, it'll be interesting to see, and I'm just taking some wild guesses, what I'm looking at here and what I'm going to see in your ACM assessment, because that amount of compensation, and I mean, what I mean by that is the shoulder humerus, it has an internal and external rotation capacity. More muscles are responsible for internal rotation of the humerus, meaning the pec, the lat, and the teres major, plus your subscapularis. But you only have two small muscles that are external rotators, the humerus, which is the infraspinatus, and teres minor, your rotator cuff muscles. But they are overpowering the three big muscles of the shoulder girdle to externally rotate your humerus, and then that forces you to pronate your hands because you have to get your hands into a functional position. So I call these like the doggy paddle walkers. They probably don't get, it'll be interesting to see a gait pattern too, how much authentic arm swing you get versus elbow swing you get. But that's from these static postures, that's the big thing that's jumping out to me. And then that ties into probably some of the lumbar extension you're getting. And we'll be curious to see what your lat looks like and how you move through some patterns. That's what's jumping out to me. Anyone else? Any thoughts? I'm curious about Matt's, or even what your thoughts were, Deb, from your static posture. Like, we got to find a place to start, right? You've got a shoulder elevated, you got a pretty significant hip rotation, you've got asymmetries in your knees. Where do we start with all this? So
that's a great question. But and one of the, as I said, I think the shingles really just my upper body. I totally lost. It has been very significant how much strength I've lost. I used to, yeah, and again,
it's that autoimmune nervous system.
Yeah, it's really
condition.
been bizarre,
and so there's definitely some stuff that I think excites the nervous system and tones it down. And again, I think all of us agree that poor posture, and I don't even like calling it poor posture, this is just a strategy you use to stay upright. And for whatever reason, you're using these strategies that create the body to change and shift and move and do things that create a shift in your body's position that works for you for now. But with obviously the ramifications of discomfort, pain, and dysfunction. So, but this is a strategy. We got to figure out how do we correct the strategy? What strategy do we need to address first to get this thing back in line, right?
Yep.
Yeah. Okay. So that's our static posture. So let's go into the assessment, the ACM. So now that we have this, do you have a gait pattern or not?
Yeah. You want to see that?
It's yeah. I'd be really
bad,
curious.
But let's see. I was like, this is really bad, but
well, there's your short sleeve shirt picture. That's okay.
Oh yeah, no, it was so bad. I had to put more clothes on.
Oh, that's okay. That's okay.
Okay, so gait. Here's.
Yeah, well, good enough.
Let me make this bigger. Okay, hopefully that works. Oh, that's weird.
What's that?
The video, it looks like I was stopped.
No, you're moving there in it.
Yeah, weird. So do you want to see it again?
Yeah, just one more time.
They only give you like 20 seconds.
I know, that's okay.
Yeah.
I mean, without seeing your knees hit the ground and all that, it's a little challenging, but well, you do get arm swing. That's good to see.
I walk a lot. I walk every day. I walk my dog, but it's not always, doesn't always feel great.
Yeah, I can see it. Go back, hit it again, hit play, and get ready to pause. I'm gonna tell you when to pause. You'll pause on the way back.
Hang on, I need to, how can I do that? It's got annotate where I have to hit play. Hang on. Here.
And if you can pause it on the way back when you hit your right foot on the ground, left foot on the ground.
Oh. Left.
Right. Next one. There.
There.
Stop. Look at that. What do you see?
I'm not very good at gait.
So
But
if we think of symmetry, look at how far when you are completely unload bearing on that left leg and your whole hip shifts off to the left. Now take one more step. Do the same freeze on a stop. Go back to your right foot stance. Go back a little bit, or you're gonna have to go there. Stop. Yeah. You're almost there, but you don't get that. You don't get that that lateral shift on your right hip as you do on your left.
Right.
No, left. I'm just teasing you.
Left.
Stop right there. Well, you're almost off toe off on the left.
Okay.
Just a little bit more. There. There. That's about where you were on your left when we paused it. And look at how straight the line of your body is. So we know that that right shoulder, that right side that I was pointing out was doing something to stabilize something. It's always a cross pattern, that oblique cross pattern from torso to pelvis. And there's a left hip issue going on here for sure. And that's pretty obvious from gait pattern. So I think understanding like movement kind of brings out a lot more of where things are going on. That's pretty obvious. All right, so that's good. I think that's the biggest thing I've come out of this gait analysis. Anyone want to comment on that? That's the biggest thing I noticed, and without really seeing the knees. And I would be curious to see what that left knee looks like when you strike the ground, because you did say it was more valgus, which with a lateral hip shift, you're going to get a lot more valgus stress on that knee. And even pushing off of that left foot, you really go a little bit more there. Oh, you can't see it so much. But
yeah,
anyway.
it kind of so fast.
Come off of that and there. So the question is, what's going on that left side? Are you getting off of the right hip because of right hip extension, or is there an internal external rotation factor? We got to figure that out. We can't figure it out from watching you walk. We can't really figure it out from static posture, but some things are making a little sense now, right? I haven't really got a clear vision of what I would do. I would be throwing some things at you, but I'd be still hard pressed at figuring some stuff out. So this is where the ACM comes in, the next level of assessing movement. So let's go to your ACM patterns. So there's 6 patterns that you've got, right?
Okay, so I had the...
Yeah, the first is ankle mobility. So we're just looking at your left ankle mobility, and the assessment is really just looking at how much dorsiflexion is accomplished by bending the knee forward, touching the wall. Yeah.
Not much.
That's your limit right there. So on your assessment form, you had written right side is 1 3/4 inches. The goal will be 4 inches. So if we're at 1 3/4 inches, we would consider that a lack of dorsiflexion, correct?
Yes.
What scale level is your neck pain? I don't even bother answering that. I'm just going to go on from the assessment.
It's okay. You will see in the assessments, and a lot of them, when I'm done with them, I like move my head around because my neck is aggravated because of it. Everything I do aggravates my neck.
Okay. So the right leg was, go to your right leg. Or, I'm sorry, that was your left foot. So your left foot was 2 3/4 inches off the wall.
Yeah, and now you don't see it in here so much, but when I first did this, when I did the left, my hip went under and my leg went very valgus. My left.
Well, again, some of that's your compensation for lack of ankle mobility, right? Remember, it's a strategy. If you don't have dorsiflexion, then you can't bend the ankle. You have to find another way, which is moving the knee, moving the hip. Yeah. And that's your limit, right? That was less. The right side is less, right? 1 3/4.
Yeah, right.
I'm still going to give you 2. And the left.
Well, the right side is less and it's tighter, but my left leg goes valgus a lot. So in my butt,
so they're probably even at 2 inches. I wouldn't. You're almost at 2 inches on the right, but you said you were further on the left, but it probably has more compensation on that left side as you're moving into it. But regardless, the assessment calls for 4 inches. If we're under 4 inches, it doesn't matter if it's an inch or 3. It's still under 4 inches. It's a dysfunctional pattern. And in your case, because it's about an inch difference, I'd call that asymmetrically different. I don't have half-inch or quarter-inch measurements on my assessment rule, so I'm just going to give you a 2 and I'm going to give you a 1 on the left and a 2 on the right, which gives us the asymmetry. Does that make sense?
No, that's fine.
So based on what you know about the ACM, that's a big red flag, right? And the idea is we never really look at, and this is a great place to share this. I think all of us agree that this is not a joint by joint thing. We're looking at the systemic relationships to joints and the kinetic chain. But because the ankle joint and the Achilles tendon and the 7 muscles that control dorsiflexion are so big and strong, the Achilles tendon being one of the strongest tendons in the body, largest and strongest tendons, can have a huge influence on tightness and contribute to lack of dorsiflexion, which limits a lot of stuff. So this is why I've done a lot of research behind this, and ankle mobility is one that you really have to go after directly, not as an influence of more hip extension. So because someone has lack of dorsiflexion, meaning they can't get that ankle to bend when they go into a stride length, then the hip doesn't go back. So is it the hip's fault or the ankle's fault? And you can argue if you did a lot of hip extension, the ankle will have to start moving. But because of the size and thickness of that tendon and strength, you have to address ankle mobility head on, right? Jeb, we've talked about that directly, right?
Yes, Mike. Yeah.
So, okay. So there's your ankle mobility. As we're talking, as you're showing the videos, I'm putting it into the assessment software so we can just look at it later. All right. So let's go on to the next assessment, which is the next assessment is a toe touching pattern. So now we're going to look at, we're moving up from the ankle joint to the hips. So let's see.
You want me to do I have a front view and a side view.
We'll just do a side view to start with, see if there's anything that jumps out to us. So we're looking at pretty much from the frontal plane, we're looking at the,
why is this, oh, get rid of that.
And so we're looking at just authentic movement of the SI joint. Good, can you pause it?
Oh, sorry.
That's okay.
Yep, I'm gonna do it again.
So we know you've got a pretty strong lumbar curve. Moving down, does that lumbar curve release? Somewhat stop. And it's pretty symmetrical, I'd say. You can touch your toes. You look like you have pretty good symmetry, but then right at that thoracic back, we get an extra bit of kyphosis, right? Following that extension or that flexion.
Yep.
Right? So right up to about where your bra strap would be, you have a pretty symmetrical curve of the lumbar spine, which looks good. We don't want that lumbar spine to be flat. Your SI joint, your sacrum moves to probably 80 degrees that we wanted. That looks good. And you can touch your toes, not that there's an Olympic event in it, but you do get a little extra movement in that thoracic back and kyphosis, right? And going back to your initial symptoms about neck pain, I would say from my experience in the thousands of people I work with at offices, people with neck pain typically have a strong kyphosis. And because that translates to put this person the way you're sitting right now, horizontally flip this picture, that's how you sit. Your head comes forward as your back rounds, and it has some strength from your mid-thoracic to your lumbar to maintain a nice symmetrical curve of that flexion, which is okay, like a cat and dog, right? Nothing wrong with slouching, as long as it's symmetrical. But you break at that thoracic junction, like T8, T10, right in that area, and it just collapses down. And that's where that some of your dysfunction is coming from, excessive kyphosis. Now, does that mean it's tight? I don't know. We don't know just from this image. So we'll look at some more. Let's see the sagittal view from the front. Does that all make sense, Deb? Is that what you were going to say? Is that what you noticed with your thing? You said you didn't look like a lot of my people that are the pictures I had.
Yeah, well, yeah, the curvature looked kind of different than any
Well,
of
yours
the.
yours looked symmetrical. It was rounded, but I wouldn't say it was excessively rounded. There's a little bit of subjectivity in this, but the biggest thing, we'll go back to it in a second. Let's just see one thing here. If we could pause it when you get down to the bottom. Yeah, it looks pretty level from my standpoint. That left hip might be a little bit higher. I
The
can't tell.
right, right. That's a little higher here, and you can see I'm a little.
You offset. You
Yeah,
offset. You offset to the right. Yeah.
yep, yep.
And so that's curious. And again, we knew that from your gait there was a shift in your pelvis, and now we're starting to see this asymmetry come out. Even though toe touch is like a bilateral movement, we can see the asymmetry in this position, and so we're starting to get suspicious now. We're starting to make sense of the asymmetries we saw in your static posture, the asymmetries we saw in your gait pattern. Now we're seeing it come out in your toe touch, so it's being consistent. All right, that's
Yep.
good. To go back to your.
And also, you can't really see it in these photos, but my left, and this is better probably than the last time I did this, probably because I've been doing some other exercises. But my left like erectors are more bulky, I
Yeah,
would say.
that's what I meant. It looks higher, which means
Yeah,
it's
they're
probably just
different.
thicker.
It's
But
hard
it's
to.
also part of that offset.
Hmm.
Yeah, and again, I don't know if you remember this, but what is also synonymous with toe touching in the hip?
With toe touching in the hip. Oh, the internal femur
Yes.
rotation.
Yeah, so internal rotation of the hip socket. So if your pelvis isn't going, we already said go back to your side view.
Okay. Also, the two, I didn't do both side views, but they look
That's
different.
okay. They probably look the same, right? We really can't see much of asymmetry from either side.
What I mean is, I go down, but I think on my right side I actually go down better. I have a bug on my screen. Um,
Oh, we can't see it though.
okay, there
And
we
then
go.
pause it at the bottom. So if you looked at just your black part of your pants, that SI joint, your sacrum, is at a good 80-degree angle. So we're not arguing that you have good mobility there, but there's definitely a difference right to left, especially the fact that you know that you shift over to one side. So we'll find that. We'll hope we know there's a difference because we've seen it in all these things so far. We got to dive deeper and figure out where that difference is.
Hmm.
So toe touching, I'd say you can touch your toes. How hard is it to touch your toes on a scale of 0 to 10?
Yeah, I mean, I would say that was probably around a 4.
Okay, so that's not that significant. Your back does round. I am going to put your back rounds more than it should, especially at the thoracic area. And I'm going to save that. Let's go to the next one, which is the backward bend pattern.
I would say if I did this in the morning when I got up, I couldn't touch my toes. That's
Okay,
that.
so 4 gives us a level of difficulty that's up there. It's pretty authentic, but you do have some rounding, which gives you a compensation. So yeah, the backward bend.
So I have backward bend side and back
We'll
views.
go for the side first because all we want to see is if your what your hips and shoulders look like when you go into it. So pause it when you raise your arms up overhead. So the first part of the assessment is there. Stop. So is that true shoulder flexion? Remember I mentioned to you, I'd be really curious about your lats because of the arm position when you're standing and where it looks like you're getting stability from that large curve of your spine. With someone like you who doesn't get true, you don't get full 180-degree shoulder flexion. Would you agree or not? Do your arms
I would
go?
agree.
Yeah, your arms don't go perfectly straight overhead. They
No,
probably get
correct.
tight. I'm sorry.
That's correct.
They get tight up there. So that's showing some lat engagement. And again, that was my question before I even saw this from your static posture. And this part of the assessment, I'm already looking at this thinking there's some lat tightness here just based on how strong that lumbar spine was when you bent over to touch your toes, as well as this position in the arch of your back. So now continue the video. Now we're going to see how much hip extension you get meaning how far the ASIS passes forward of your toes. Pause it right there. So now I'd say you get pretty good hip extension. If you drop the line from your ASIS straight down, it's way out in front of your toes. If we measured that hip joint angle, you're probably beyond the 10 degrees that's required for hip extension. So you get good hip extension here, but you get zero thoracic extension and your arms still don't go back. Now they're at about 180 degrees of regular dorsal shoulder flexion, right? You're very stiff in your thoracic back.
Yep.
I'm guessing just from this assessment so far. We're going to find that out in a second. But this one is already starting to show me is like that thoracic back is a very big compensation for you for probably some weakness down below. But anything you want to point out here? If we were to draw a line from your shoulder, basically the line of your scapula, the scapular line down, that probably wouldn't pass behind your heels, which shows really unauthentic. You get a nice lumbar curve, but you already had a strong lumbar curve to start with. The further you go up with your arms, the more that lat pulling your lumbar fascia, getting you more of a lordotic curve. But the thoracic spine doesn't have that extension capacity, which should have the exact same amount of extension as the lumbar spine does. This lumbar spine will stop at about 45 degrees of lumbar flexion or extension, and then the thoracic spine should kick in and get just about the same amount. So we have a very tight thoracic spine here from this assessment portal. Is that what you would think, Deb?
Yeah, I mean, it seems like
you feel when you do it?
Yeah.
You feel tightness in your hips when you do it?
It doesn't feel I don't feel stable in it, especially, it's interesting because I feel more unstable specifically on my left leg.
Yeah.
And
again, you saying that also brings me back to your gait pattern. Which leg was the one that was shifting off?
The left was.
Yeah, so it's starting to make sense, right? A big part of this backward bend that even this is still, it's not necessarily going to tell us that she has really tight hips or a tight thoracic back. All it's telling us is it's not a functional pattern, but it doesn't tell us why. And what do I mean by that, Deb? Because what else could be happening here? Your inability to bend backwards and maintain stability requires what? Well, it requires stability, the ability to balance and be able to fall back that way. If you don't have that, then you're not gonna be able to go through that end range and still be able to stabilize it. So it may be, and that's why each one of these assessment patterns kind of gives us some insights to, is this a tightness problem, a true like joint restriction, or is this a stability problem, a strength issue? And so far, I'm not really looking at a joint restriction other than those ankles. And again, your ankle mobility restriction doesn't show up here as much, and it could because you do get pretty good hip extension here with the poor ankle mobility that you get. It'd be interesting to see if what your knees are doing to accomplish this, because you have to go into dorsiflexion at the ankle joint to get hip extension, right?
Correct.
Yeah, and so it'd be interesting to see what your knees are actually doing in this position, or even if we improved ankle mobility, what would look like, what this pattern will look like again. But anyway, that's going from there. We just know from this there's some tightness going on. Now that tightness is based on trying to maintain your new position, dynamic stability. Is it your strategy to establish that dynamic stability of the backward bend, or is it true tightness because of strength demand somewhere else? So we'll figure this out as we keep going. So your backward bend, I'm just putting this data in. Your ASIS does go over your toes, your scapula doesn't. On a difficulty scale, how hard was this? I think you put in here, it was a...
I don't think that it had it. Backward bend it didn't really have a thing for difficulty. It was.
Oh, okay. But how was it hard?
I would say definitely it was harder than,
so like a 5 or 6?
Yeah, probably.
Okay.
I could do it, but it wasn't comfortable or stable.
Yeah. Well, there you go. Stable, right? So let's look at your standing. The next part of this now is your standing rotation. So far we've looked at ankle mobility. We looked at the toe touching pattern, which is the flexion pattern of the hip. We looked at the extension pattern of the hip and the spine. Well, we actually looked at the flexion patterns of the hip and spine. We looked at the extension patterns of the hip and spine. Now we're going to look at the rotational patterns of the hip and spine. Oh, you put it on your hips. Look at you.
Yeah, and my husband made this, took a hula hoop and made so I could.
So before, yeah, go ahead and open it. But before you start it, I'll just share with people what this is. We're looking at when someone does a standing rotation. I do want people to do it with the arms out in front of them, like pointing at, arms straight out in front, hands clasped together, or arms across the chest, because I do want to see the thoracic contribution to the rotation. And that goes later on into what we talk about. But this is, for the sake of argument, we wouldn't be holding the dowel at our hips. Deb did this to have a better visualization, but we'd want to be holding it up on our shoulders. You don't necessarily hold dowel, but you just have your hands clasped out in front of you, and you rotate to one side, rotate to the other. And that's what we're looking at here. But from the assessment standpoint, what our interest is how far does that dowel or her pelvis rotate to the right and rotate to the left. So go ahead and, does that make sense? You understand that, right, Deb? Obviously, because you're holding it on your hips on the dowel.
Yeah, I originally did it, like you said, crossed, in the sitting.
And you probably just were looking at or feeling how much you rotated around, right? Versus what your actual pelvis did. Because when we're looking at the pelvis, this gets a little confusing. Right? It got a little confusing when we were going through this with you, right?
Yeah, I was struggling because looking at what the hips were doing and separating that out from
so we'll just go into one rotation, one direction, and then we can stop it there, and I'll share with what we're talking about. Yeah. Oh, just pause it there. That's it.
Yep.
Okay, so that's rotation to the right. If you guys can imagine, the pelvis just rotated on a fixed femur. We don't necessarily say it's a fixed femur, but it's not, the foot doesn't turn out, so the femur is essentially fixed. So that pelvis is rotating over top of the right femur, which is turning internal. The femur of the right hip is rotating internal, or you can say the pelvis on the right hip is rotating external. But I always say the internal rotation on the right hip, external rotation on the left hip. Imagine standing and rotating to the right. The left foot, the left hip is turning out on the pelvis as the right hip is turning in on the pelvis. I hope that makes sense. This is where you and I got into a big discussion to help you understand it, right?
Yeah, and I mean, I got it fixed, but it still doesn't really.
But it makes sense what I'm sharing with you?
I get it, but it still blows my mind that that's how it works.
Well, that's what's happening though, right? Anatomically.
Yeah.
Yeah, it's kind of like, think about like the way I explained it to you, and I'll share it on the call, is think about the difference between doing like isolated hip flexor lifts. It's an open chain exercise. The pelvis is stabilized on the ground while the femur is moving in the socket, right? Versus a cat and dog, where now the femur is fixed on the ground and the pelvis is moving over top of the socket. That's the difference. This, with your feet on the ground, is a closed chained exercise. So the femurs are essentially fixed while the pelvis is rotating over top of it, which is a lot of the patterns of walking. You have to be able to load a hip joint, and the pelvis has to move over that fixed femur for it to work appropriately. I take this to another level. I work with baseball players, throwers, golfers, and that rotational component out of the pelvis is where all the power is generated, and dysfunctions, injuries like shoulder injuries, elbow injuries are a result of, even back injuries, are a result of the inability to rotate it in those hip sockets and the compensation that has to happen up the kinetic chain. And so this is a valuable tool, probably one of my favorite, I start identifying some really significant issues with people. So now let's look at so I would say if you have these marks on the hula hoop, that white mark at 45, I'd say, I can't tell from this view, but are you close to 45 on the right?
Okay, so no, and it's yeah, you can't tell from this view.
Yeah, you said you're 30.
Actually,
on the right hip rotation.
No, right hip rotation was only 25 and left was 35. So yeah.
Okay, let's take a look at you going both directions. We'll watch a couple of times without stopping it so we can see. We'll stop it when you go to the left and just see if there's a noticeable difference.
All right. I don't think there is as much in this one because the measurements I got when I did it before. But anyway.
Well, yeah, it's kind of hard to say 20 degrees and 25 degrees.
Yeah, my husband.
Stop right there. You get stuck. I can see you. Go back to do it again. We'll have to. Oh, you got to replay it.
There I go with my neck.
Yeah, again.
There's that.
And so I'll just show you. Go, keep going. Yeah, you stop right there. You definitely are stuck. I would almost give you the even on that side, but you're stuck. You don't get to 45. I'd maybe say 30. Again, I'm not measuring it with accuracy, but I know 45 degrees, you're not at 45. You're definitely around 30. I'm just going to call it 30 degrees, which doesn't matter. You're not at 45. So you're on either side. So it would be considered dysfunctional. And it looks pretty much the same on both sides from this view. Black is really hard to differentiate in a two-dimensional like this. But it's
I know.
tight.
I only have black.
The other thing I'm going to share with you, and this is something that we talked about with your husband, was this disassociation of the pelvis and the torso. And this is why I like to see the upper body moving as well. I want to see if the pelvis should go to about 45 degrees, and then the torso should continue another 45 degrees, which gives us almost a 90-degree angle. That stick should be pointing straight at us if it was across your shoulders. Now, I look for that disassociation. I look to see that the pelvis and torsos can separate themselves because that's a very impactful functional anatomy, basically, that we get disassociation of that torso and pelvis, which is why we have arm swing, which is how the body works, right, to reestablish balance top to bottom. So it's hard to tell with this because you're not moving the torso. And then to compensate for the lack of rotation, where do you force the rotation to occur? Further.
I'm sorry. Say what?
Yeah, I know. I talk like that. So by holding the stick in your shoulder, in your hips right now, and rotating, you mentioned it a second ago. As you rotate and you're not getting that rotation out of the thoracic back to get further into the rotation, where are you going to find that rotational component to make up for it? What was the last thing you did at the end of that movement?
Oh, my neck?
Yes. Look at your neck's trying to turn. Look at your sternocleidomastoid on that right side. It's pulling your neck around, trying to help you get that rotational component. It's almost like it's pulling the torso with it. And so this is why it's so important to get that disassociation of the thoracic back. And again, going back to what we've seen so far, we've got some tightness in this thoracic back that we suspect. We've got some stability issues going on that are showing us some overcompensation, over-patterning strategies that you're getting out of your neck. All right, so I would agree. Would you agree that you're not at 45 on both sides?
Definitely not.
Okay, so we're good with that. Able to rotate 45, no. Able to rotate 45, no. Okay, so the assessment. We can move on to the next is sitting rotation, right? So what we've looked at is essentially we've gone from the ankle to the hip sockets and looked at internal and external rotation of the hips, flexion extension of the hips and the spine. And now we're looking just at thoracic rotation. And now we're going to get some of our cues, our curiosities met here by looking at, does the thoracic spine rotate to 45 degrees? Because now we've got a fixed pelvis, and now we're just looking at the true rotation of the spine. And I was sharing this with you, Deb, about the facet orientations from the lumbar spine to the cervical. And when you start at the lumbar spine, the facet orientations, the joints of the lumbar spine are orientated almost in a vertical position. As they start coming up from the lumbar spine to the thoracic, they start migrating to a semi-horizontal all the way to the base of the neck, C1 and C2, to a perfectly horizontal position, which allows for more rotation. So what that means is as we come up from a lumbar spine or down from the neck, we get more rotation out of the neck, more rotation out of the thoracic back, and less as we go down to the lumbar spine. We know that the lumbar spine is not designed for rotation because of the facet irritations or the facet orientations. So the thoracic back does have mobility. It should actually have a lot more mobility than most of us think, over 45 degrees of rotation in this sitting position. And that's what we're looking at, right, Deb?
Yes, and I don't have it. So
let's take a look. So that's all we're looking for. Boom, you're stuck there. It's pretty obvious. And then the other side. Boom, wow. You didn't tell me all this, Deb. Yeah.
I think I could.
So you'd agree you're not even at close to 45 on either side, right?
Yeah. Previously, I think it might be more balanced there. Which is
again, this is where
20 and 40 was what it was when we really looked at it before.
Okay, go back to the right one. We'll just do it one more time. And then stop right there and look at your sternocleidomastoid. You know what that is? Like from the earlobe down across the neck.
Mm-hmm.
Just take a look at the left one, and you're getting more rotation to the right, definitely. Because when you go to the left, watch what happens to that sternocleidomastoid on the left. Stop. You see it?
Well, that's the right.
Yeah, but it's your right sternocleidomastoid as you're turning to the left, which is what the sternocleidomastoid does. It pops right out, much more, and that's where your neck is trying to pull that your rib cage around for lack of rotation there.
Yeah,
it's interesting.
Well, what's interesting to me is when I'm sitting. Previously I got, let's see, what did you say? You said I got more which direction?
It looks like you got more rotation going to the right.
To the right.
Yes.
See, when I did it before, I got more going to the left. But in standing, I got more to the left. But here,
just from what I can tell in this picture, if you did it a couple more times, it just doesn't look like you open up as much on the left as you do the right.
Yeah. I think it's gotten, like I said, I think it's gotten more balanced from the first time that I did it, that's a good thing, but it's still limited.
Yeah.
Mm-hmm.
Yeah. Those are indications I'm looking for. Now, you mentioned it doesn't look like you say it could be because of stability or balance, which is a big part of it. That looks like you go a little bit further. It's hard. I can't really.
Well, okay. So historically, Mike, I do not rotate as much to the right. Period. It's harder to rotate to to
Okay.
But I don't know.
Yeah, but we're still not at 45 degrees, so it's still considered dysfunctional, which kind of confirms with what we saw with your backward bend, with your hands overhead, with your toe touching pattern, that thoracic kyphosis. So it shows some tightness there. And the other one is going to be your standing mobility, your standing single leg stance. Well, let's look at the back one. Since you have a sitting back rotation, maybe we can see a little bit on that.
I found that with this, and I probably should have done it. You can tell better getting a side view sometimes.
Yeah.
But doesn't look great either way you look at it.
It doesn't look like a gross disparity, and if it is, it's marginal. Not arguing over 45 or not.
Yeah.
We're just looking for tightness because asymmetry. We're not going to fix one side. We're going to fix both. But
yeah.
So the last part of this is we've pretty much gone from the ankle to the torso as far as mobility is concerned. Looking at some gross mobility areas that are essential for movement, and kind of putting some pieces together. They all relate to each other. Now we're just going to look at a simple kind of a Borg. It's called the Borg's modified Borg test, where they look at just overall balance, stability on standing on one leg. And do you have it from the front or just the back?
This is the ankle, or this is the shoulder mobility.
Oh, okay. We can look at that one. We don't really score this one. This is just more or less to confirm. But because you have tight thoracic muscles, musculature, and thoracic spine, I'm not expecting to see miracles here, which is what I expect to see. We're not seeing a lot of scapular movement. And again, we don't see a lot of thoracic extension. So if you had tremendous rotation in your thoracic back, you had tremendous backward bend pattern, you had a pretty strong, flat thoracic spine, it doesn't even matter in toe touching, but you had that mobility in your thoracic spine, and then we saw a shoulder mobility test like that, then I'd start looking more closely at the shoulder joint itself, the shoulder mechanics, because I've got to address the thoracic spine before we get into the shoulder specific mechanics. So this is your single leg stance?
Yes. Now I had to go off the carpet because I could not stabilize at all.
A little unbalanced, but that's okay.
But
So
I was
able to go with this one before you start is we're basically having her lift her knee up, one leg up to stand and balance on one side for 10 seconds. And then without putting that foot down, reach back with the leg into extension and try to hold that position for 10 seconds. So we're kind of just throwing the body off balance a little bit, see how her body reacts to it. So this, I will tell you, kind of it's a big insight to how much stability someone has and where they create stability. Remember, it's a strategy to remain upright on 2 feet, single leg stance type of for instance, like walking is a single leg stance activity. Same with this one. So we're looking at that strategy that she employs, and the more arm involvement, the more swaying and twisting and all this, there's just strategies to maintain that upright posture like a tightrope walker. So that's what I'm looking for. Whether she can or can't isn't as important as to how she's trying to accomplish the pattern. And again, I'm looking at that arm position already starting, how tight she's locked in with those elbows to her side, because she's probably anticipating what's coming. Let's take a look at what happens.
and it is slightly less than 20 seconds to, so.
That's okay.
With that left leg.
Yeah, but look at the the arm starting to flare out.
Yeah.
And it's just rigid up there. You're not relaxing those arms. So you're stabilizing a lot from that upper torso. And then look at your neck.
Yeah.
You're like, oh, right? All that tension. It looked like you were holding a tightrope pole to hold yourself there. And that's why that neck is so tight. Watch the arms they get further and further out. They're starting to climb out. They're getting tighter. Yep. You're engaging that upper trap, the rhomboids, all that musculature to stabilize you. External rotators are going out crazy now. Yeah. And then do you have the left side now? So yeah. I would say, look, you accomplished that. It looked good, other than what I'm picking on you at, but it looked okay. That was on your right leg. You're able to do it, but how difficult was that? Yeah, it didn't look that hard.
It's definitely harder going back.
Oh, but you stayed up and you were good. I scored that as a functional, but I'm going to make a note of what I'm seeing with your arms, which is exactly what I saw in your static posture. And then we also saw that, as we've confirmed through all these assessments, that stabilization is occurring in that upper back, which is why all the next stuff you've done hasn't helped, because you haven't fixed the underlying cause. Oh, let me add Jennifer Fuller here. She just entered. Hey, Jen, we're still going. Jen, are you here? Let's see this left side.
Right. This is the right.
Oh, I'm sorry. Yeah. Okay. So right leg. And look at those arms. Look at that right arm. Yeah. Relax your arm, Deb. You got your hands are like a claw. I'm just teasing you. Okay, so you're able to do it, and it looks pretty easy. But I would put a note here of that thoracic compensation, that the external rotation of the humerus, and on both sides, especially that right arm. Do you agree, Deb? Do you see that now?
Yeah, I mean, definitely. And I mean, like I said, I can feel it in my neck. So if it's bugging my neck, then it's got to
Yeah,
go up my
but
butt.
you weren't flailing around. It showed some stability. It probably showed. It probably really showed. Let me make sure. I've got a couple of people that have been. I've been letting in. Jen, you here?
Yes, I am. Hi.
Jen, great. Hi, Jen. And I think I just let someone else in.
I saw Matt there, but he's gone
Yeah,
now.
Matt had to leave, I think.
Okay. You
And
just
we had
you just
someone
started.
else. Wait, oh, Stacia. Hey, Stacia.
Hey, sorry, I was on the road and now I'm on the computer. So
That's okay. We're like right in the middle of going through all this with Deb, and so you'll get the chance to see the beginning of the assessment. We were just talking about all the different things we just saw with Deb's movement patterns. I'm going to share my screen so you can see what we just did with this software. And I want to state something again. I'm not trying to sell you guys software to use. John Lemmy's software is really good. I don't have the ability to using this. We don't have the ability to put in exercises and all that kind of stuff that John does. This is really just an assessment form. This is the one you guys can see my screen.
Yes.
You can see the handwritten assessment form.
Okay, yeah.
Okay, that's the one that Deb filled out and sent to me. And we just went through the assessment. This is what I teach them how to use this form, which is exactly the same thing as the assessment that we just did. Ankle mobility, she scored an ADF, which means asymmetrically dysfunctional. The difference from right to left.
Hey, Mike, Mike, we're not seeing the screen. I just unshared. So, because I think I was still sharing. So can you share now?
I'll do it.
Okay.
Screen 3. Everyone see it now?
I can see it.
yep.
You guys can see the handwritten one?
Yeah.
I can, but it's not very does it matter that we can't see it exactly, like up close or
No, I got to zoom in to see
Yeah.
it.
Okay, super. Okay.
Yeah. But
Yeah.
basically this screen is the same thing as this, and so
Yeah.
I'm not gonna.
I
you guys
see.
don't have to use this software, and it was a supplement I built into the program. But I teach you how to use this paperwork because it's the same thing. And when you know it, you know it. You don't have to rely on the software. The software had some other implications that we were using it for, and it's good, but it's not really necessary. You guys aren't going to be able to build a menu from it. The only thing it will do is now that I've assessed Deb, it takes this algorithm of what we assessed and says what's the highest value here, what's the one that's most important to address, because what Deb was sharing with us, because I think Jen's been on. No, you guys are the only two that are on that for a while, right?
Yeah.
Yeah. Okay. So we went through Deb's whole assessment and her
Oh.
postural assessment. Do you want to share that again, Deb? Well, anyway, her postural assessment was probably what you guys are used to seeing as related to all kinds of stuff. She had a shoulder elbow. Yeah, go ahead and show it. I'll stop sharing.
Okay.
And Mike, I've been
we've already
listening
pretty
in
much
when I was
gone
on
through the
phone.
assessment from a static posture to her gait analysis to the ACM and what in the insights that we gained by doing a movement pattern assessment, how we correlate that back to Deb's static posture, right, Deb?
Yep.
And it's starting to make more sense and is all pointing to where we need to probably focus. Did you get it, Deb?
No, it kicked me out for some reason. I don't know why. I don't have the authority or whatever to do what I wanted to do. So I just got to log back in.
It says multiple participants can share. It says you can share now.
No, not that. PTX kicked me out.
Oh. Well, Deb's static posture. You guys can see it at the beginning of the video if you want. It was really just showing. Shoulder elevated and a big rotation in her pelvis. Valgus knees. One was valgus, one was medial. Arm positions, and that's what from the static posture. That's really what I focused mostly on was her arm position. It told me a lot about what we were probably going to find throughout the rest of the patterns, and it was pretty close to what I guessed, wasn't it, Deb?
Yeah.
Because I hadn't seen your static posture before. I hadn't seen your static posture. I hadn't seen your gait. I hadn't seen any of your patterns. And from what we assessed from your static posture, it translated pretty closely to what I found in your movement pattern assessment. So what we found, got it?
I just pulled it up so I can, yeah, if you want to,
Because both of you, Station,
activate
Jen,
data.
you guys are posture people, right? You look at static posture.
Yep.
Yeah.
Yeah. And gait. I do a lot with gait just because that's,
Sure, sure.
you
Well,
know,
again,
I don't know,
gait is a
for
dynamic
whatever it's
dynamic
worth, right?
stability thing, right?
Yep. Sure.
And there's a lot going on with gait to really understand it. There's a lot of nuances to it. Did you get it, Deb?
Yep, it's up.
I'm sorry, I kept going back and forth of calculating the time, so I miscalculated by an hour.
I do
so
that all
sorry.
the time.
Oh my
So
God.
take
So
the green sticks off, if you don't mind, Deb. Can you?
The what?
The green
they
sticks.
take the show analysis off.
Oh, I'm sorry. Yes. The green sticks. Sometimes those things come out or not. They're not very good sometimes, but whatever.
So I'm just curious from you two, what's the biggest thing that pops out to you?
The right more anterior, it looks like, and then pushed it's elevated. It looks like from behind, but it looks like anterior.
The pelvis.
Actually.
More than the left, that's true. Yes.
The right, yep.
Yeah.
And when I just came on and I saw you standing, I thought, oh, that's internally rotated in the right. It looks like.
Yeah.
Yeah, you got it.
And so what would you start focusing on? Hips?
You know, are you asking me? I don't want to just.
Oh yeah, and I'm not putting you. I don't want to put anyone on the spot, but I'm just
I'd love
trying to understand like
It's
what you
fine.
guys see as experienced posture people.
Yeah.
I did this for a long time, and I was guessing. I was like, well, maybe this will work, and this is what I found to be a frustration. Not for you guys.
Totally.
This whole thing wasn't built for you guys. This was built for me to learn it because I was working for myself, and I needed to be effective for the price I was charging, for the price companies were paying me. I needed to make
Right.
sure I could deliver 3 exercises to
That's
somebody
awesome.
and be effective at it. So I had to really identify where the biggest problems were. In order to do that, I had to see more things happening. And so gait made a sense, but it wasn't enough for me. I still needed to see more.
So because I'd love to say something because I missed the whole other hour.
Yeah,
So
Jen,
here,
sure.
I'll throw it in. So the biggest thing would be what goes through my head is, okay, we got to get pelvic disparity out, but it looks like a shoulder disparity too, big time. You know, like, so the two are not coordinating. So I would go after the psoas, the iliopsoas, and the hip flexors first. And
Why? What's wrong with hip
because
flexors?
okay, to get some better communication between the shoulders and the hips. And then I would go after changing the shoulder and hip position. But I think I don't know, it's a go-to, but a lot of times I go to hand leg opposite block now because I find I can absolutely get bigger changes. It just depends if the person can do it right away.
Right.
Does that make sense?
So forced hip extension with contralateral shoulder flexion.
Right. Exactly.
Yeah.
Gentle. I modify it a lot, like out to the side or hands underneath. And then I'll go after the changing the hip, meaning getting it to work more equally. So here goes the language out the window, right? Because it's like the guessing thing. So
well, again, but this is what frustrated me because everything you're saying is what I used to think.
Yeah.
It makes sense to all of us, but I know a lot more now from an assessment, and you guys would have. We'd probably have a little different conversation had you seen the beginning of this, and we went through gait analysis. But I'll tell you, the biggest thing that jumped out to me, and the way I look at posture now, gait analysis, standing static, any kind of movement is whatever anybody does. I don't call it anything but a strategy to remain upright on 2 feet. So the strategy that she's presenting here, the biggest one that jumps out to me is the lumbar curve, the tightness of her her lumbar spine. It's very rigid. You can just see it in her stance, and the humeral position. We call it the carrying angle of her arm. She's externally rotated at her humerus, and she's pronated at her forearm. That's the
Okay,
biggest thing that
got it.
jumps out to me. I see the elevations,
it.
I see the rotations, but that doesn't really tell me anything. Why is the torso that's just going on for a ride creating, that is her strategy. She's creating a strategy
Got
here.
it.
Her number one complaints were neck pain and right wrist problems.
Okay.
And this is exactly why. When we see it in her gait, and then when we see it in her rotational patterns, everything makes sense. But
Okay.
the biggest thing that what we haven't talked about, we've assumed a lot of things, but the first thing that we did, if you wanted me to share my photo now, my thing,
Yeah.
was her, from her analysis, and we can get on separate calls some other time. I can go through this stuff with you guys,
Yeah.
the assessment, or you can watch the call. Why is it?
Yeah.
Am I
Watch the
sharing?
call for sure. Yes,
Yeah,
you
we-
are. Yeah.
Okay.
Yeah.
Oh, there you guys are. The assessment, we look at ankle mobility. I'm looking at how far her ankle moves. I don't care about the rest of the body. Ankle mobility is one of the underlying factors that is overlooked almost in everybody. And the reason why I look at, and you guys are all practitioners in understanding kinetic chain, right? Like Jen was saying, the connection of the hip to the shoulder and the association. I call it a coordination and a disassociation. The shoulders should disassociate from the pelvis, and there should be a coordinated events with the shoulder and pelvis as well. All that's said and good. We understand this kinetic chain connection, and we all focus on that, right? But we rarely do we look at the contribution ankle mobility has. And the problem is the amount of tension that's developed in the Achilles tendon, the largest, strongest tendon in the body, has a huge influence. And if there's a restriction there, we better address it head on, because I don't care how much leg block you do on hip extension, forcing hip extension, stretching hip flexors. If you get better hip extension, it doesn't necessarily mean that Achilles tendon is going to let go, because it's already established a shortened position. So and this is my professional opinion, and I've seen this now with almost everyone I've worked with. When I've identified an ankle mobility restriction, I go after it first. And the algorithm of my software says go after it first. My protocol says go after it first. It has to be a component to the initial phase of treatment, because if you're not addressing the tightest, strongest tendon in the body, you probably aren't going to get around it by just getting a little extra hip extension and that stuff. So ankle mobility came out as probably one of the worst patterns on her body. We have dysfunction on all of them except standing stance. Her toe touch wasn't bad. I gave her dysfunctional only because it wasn't perfect. She had a little rounding. It was pretty decent. I wouldn't say it was that bad, but there was some asymmetry. The backward bend wasn't really that bad. She had a really tight thoracic back in extension. Her rotation, standing rotation, was the biggest problem. So what standing rotation is, I'll show you guys the picture. And then Deb, I want to ask you some questions, because you were supposed to do this for me, right? You did some additional assessments. What standing rotation is looking at when someone's standing, I'm looking to see how far the pelvis rotates to the right, and then how much disassociation there is in the thoracic back. Do we get 90 degrees? Do we get 45 degrees at the pelvis and another 45 degrees at the torso? I don't really mark the torso yet. I'm just looking at it, but I mark the pelvis. Here, this girl is rotating to the right. She's rotating her pelvis to the right, which means that she's getting internal rotation on her right femur, external rotation on her left. Do you guys see that or not? Does that make sense?
Yeah, definitely.
Okay.
Yep.
In this, on this girl, she's my model. She rotates to, I thought she was going to be perfect. She was a fitness girl. I put her on this test. Can you see the problem? Deb, can you? Okay, so we've got 45 degrees or more on the right hip rotation. That tells me that she's got adequate internal rotation on her right femur, adequate external rotation on her left. That allows her to rotate through this, right? But when she goes back to the left, look at how the hips never moved. They stayed at like 20 degrees. And then she just continued that excessive rotation in her thoracic spine. She gets disassociation. She disconnects the torso from the pelvis, but she got no rotation. So something's stuck here. She's not getting external rotation on her left hip or she's not getting internal rotation. She's not on her right. She's not getting internal rotation on her left. Does that make sense to you guys? We don't have to go into it too much, but it's telling me we've got a disparity here. There's a difference right to left in a rotation. Now, why this is impactful is because toe touching, the ability to touch our toes, is also synonymous with internal rotation of the femur. So if someone has a hard toe touching pattern, we just assume it's tight hamstrings or weak glutes or something, but it could just be that she has no internal rotation. She can't get the pelvis to rotate over a fixed femur as it's moving through an internal rotated pattern. And backward bend pattern.
Hey, so Mike, I actually have a question if I can interject.
Yes, this is your case.
My femurs both tend to internally rotate.
Did you measure it? Let me finish this and we'll talk about it. Because I asked you.
My question is, if you are already internally rotated, and that's where you're getting your stability, right?
I get where you're going.
Can you be lacking internal rotation because you're stuck in a somewhat internally rotated position? Yeah. Your body just doesn't want to go more internal.
Yeah,
because I can go. Does that make sense? It's almost counterintuitive for me, but I can go.
Yeah. So this is what we call anteroversion and retroversion. Do you guys know what that means?
No.
So we got the hip socket, right? The acetabulum,
yep.
and the femur head that comes up in.
Yeah.
Well, a lot of times if we turn the femur this way, we look at the neck. Some people have a neck that's turned in a little bit, which gives them more of an internally rotated position to start with. And some have a femur, a neck that's turned outward, which is called retroversion, which gives them that like pointing out position. And it does vary in people. Some people are more retroverted, some people are anteroverted. And for the sake of argument, we still, regardless of where we're at, we should still get 45 degrees range of motion there. If someone is stuck and someone who's extremely anteroverted, anteroverted means they're rotated in, which means they can't get internal rotation anymore. They're already internally rotated. That's a bony arrangement kind of thing. All we can do is improve external rotation and vice versa. Okay. So there could be a structural anomaly. Some people have them.
Right. I've had a bunch of people like that. Yeah.
Yeah. And again, we're just looking at what jumps out to us. If there's a difference from right to left and where we can make some improvements, right? That's why what I like to do so I go back to this real quick. The backward bend is synonymous with external rotation of the femur.
Okay.
And that's why when we look at internal external rotation, it also kind of helps us understand if I see someone that has a poor toe touching pattern, I'm starting to suspect they don't get internal rotation or something else going on. If they don't get a good backward bend, I'm not thinking just tight hip flexors. There could be something related to the inability to get external rotation. They may just have a lot of weakness. They may just have instability. They may have tightness in the glutes. It's hard to say at this point. They just have a hard time getting an external rotation. Maybe. So then we test internal rotation, external rotation through the standing rotation pattern. And then this is where I break it out. And this is where I shared with Deb before. To really understand, is this right or left femur or left to right femur, internal, external? We have a couple special tests. Did you do those tests?
I not on me.
Okay.
I actually did do the one where you lay down
and cross
on your
leg.
And not the cross leg. I mean, I could do it. You want me to do it right now?
Yeah. So
okay.
So I like to look at two aspects of internal external rotation. The Faber test, have you guys heard of it? It's called the Patrick's test, the Faber test. It's you laying supine, legs straight, and you just cross one like a hip crossover, but your legs are straight. You're just looking at how much external rotation occurs at the hip socket. Faber stands for flexion, abduction, external rotation.
Can you unshare your screen because they can see me. They can see better. Yep. There we go. Okay. So you want? What are we doing?
Yeah, that's good. Just like that.
Okay. You want me just?
Yeah, just like that. Perfect.
Okay. Hang on. Ooh.
Oh, look at the toe socks. Those creep me out, Deb.
Okay. So you said do the,
Yep,
okay,
yep. Cross one over the other,
okay.
and then let that knee fall out. And what will happen if you put a pressure on someone's knee, the left pelvis will lift up. So the idea is just look at true. So we get some sense of how much distance is from the floor to her knee. That's looking at flexion, abduction, and external rotation. And then we'll look at the opposite side. So this will be a quick screen for me to see if one's extremely tighter than the other. What do you guys think?
This one's definitely tighter.
Much tighter. And she was tighter rotating to her, like you said, Dad, you were tighter rotating to your left, right? You were tighter rotating to your right, which
Right.
is external rotation on the left hip.
Okay, if I rotate, hang on, I got to think about it a second.
So
If I'm
Deb's doing it, or Jen's doing it right now.
Right.
As you're rotating to, as Jen's rotating to the left, as you rotate to the right, now she's getting me all screwed up. Face us, it's easier.
No, what?
No, it's easier if you face us.
If I face you, what do you
Yeah,
mean? What?
I'm talking to Jen. She's
Oh,
demonstrating.
I'm like, I am facing you.
She's trying to figure it out. So Deb, when Debbie does this, when she rotates to the right, she doesn't rotate as far, which is showing us here that she's not getting external rotation on that left hip. And we just verified that with this. So we know that any rotation limitation that she has is coming from, at least to start with, external rotation on that left hip. Correct?
That makes sense now.
Okay. Lay back down.
Okay, so, okay, but does that have to do with the valgus?
Well,
Okay.
yeah. And then lift both knee, like lift one knee up. So you're like 90-90. Yeah, and then turn your heel out, keep your knee where it is. Look at all that internal rotation she gets on her left. Now let's look at, that's about 30 degrees. That's pretty good. Let's look at the other side. This is internal rotation on the right.
Not as much. I don't think.
But it's pretty good. It's not markedly different. So I'd say you have pretty good internal rotation. Like you even said, I tend to be very good internally rotated, but your left hip is not externally rotated. So in her standing rotation pattern that we found dysfunctional, she can rotate to one side more than the other, but it's coming from that inability to rotate. So we have a little clearer vision now that it's probably a left hip thing. What you guys missed earlier was her gait pattern, her gait analysis. We also found that her left hip was the one that shifted out and kicked out to the side. There was also weakness in that left hip. So a lot of things are pointing at this left hip issue that she has. So that's good to know. That's interesting.
The interesting thing about that is the left hip's one of the few places in my body that I usually don't have, feel
But
like I.
well, regardless, so now we have an idea of some tests we can do, an exercise, and then test it and see how it looks after, right? So let's do this one exercise and see how this works. Do you remember the airplane exercise? Or the RDL? Single leg RDL?
You can want me, I did it, but you can.
You do it, and I'll share a picture. I'll share what what this exercise I'm gonna have you do is.
Can you see?
No, you just do the exercises.
Oh, okay.
We can watch you. I'm gonna share a picture so these guys know what it is.
I can tell you that it's hard for me to do. I'm kind of unstable in it. So.
You can hold on. You don't have to balance.
Okay.
You can hold on. Which one are you gonna do?
I don't have very good lighting in here, so.
You don't need it. I'm gonna show a picture. We don't have to watch it. I know this is your show, Deb. Deb got her hair done today and everything.
I didn't get my hair done. That's normal.
No, I'm just showing the exercise I'm asking you to do. And I wanted to retest the two patterns to see how they look, if it improved at all. So just do the exercise while I'm showing them this picture. Debbie.
Well, where's the picture?
Oh, I thought you know the exercises. The RDL single leg touch rotation.
I did it once. I haven't been doing it. So
Uh-huh.
I did try it because you mentioned it, but
Well,
but I'm not, yeah, you're gonna probably have to walk me through it.
it's this one. Hold on. It's pulling up. Where's my pictures?
And the airplane thing, that's like what's that called? Scale, I think, and from Egoscue. I don't know if it's in
I've never heard of scale.
Yeah.
But this is the one that this is a huge exercise that I give a lot of people. It's like my go-to exercise. It's a single leg RDL. So you're not trying to balance. You stand on, I'm showing on from right to left. I'm standing on my left foot. My right foot's behind me as this little bit of balance. And I'm rotating my body across my right hand across the left foot, nice and slow down, and then nice and stand up and rotate back up and down.
You need to can you yeah.
So I'll do this with a lot of weight, upward of 90 pounds of dumbbell weight, just because of how much of an influence this has on the glutes and glute med. And what are we doing on that right hip? We're internally rotating, eccentrically loading the glute the way it's designed to function. And this will be interesting to see if we get an improvement on her external rotation on this left hip from this one exercise. There's another one I like to do, the airplane, that she's fighting me against.
What?
I'm teasing you.
I'll try it. Okay.
Do you feel work here, Deb?
Did
you feel that?
the left hip?
Well,
Yeah.
I knew you'd have to get up and try it, Stace. Jen, did you feel it? You're muted, by the way, Jen.
Oops, sorry. Yes, that was very clear, actually. I like that one.
It's a huge exercise because from a functional standpoint, the glute responsibility, we all think the glute max is an external rotator and hip extensor, but the glute's primary function is to load our stance leg and not allow it to collapse inward. It's to eccentrically stabilize that medially rotating femur as we're hitting the ground. Do you do both sides, Deb?
No,
Have you done both sides?
I'm doing the left or right. I don't know which are the left foot in front.
Yeah. Yeah.
Other side. Oh,
This side will be a lot more unstable and probably a lot weaker.
yes.
Stace, what are you feeling? You got too much weight in your back foot, Stace.
Oh, okay.
All the weight should be on that front foot. The back foot's just a little kickstand to hold you up.
Maybe I should take up.
There you go. Now, when you come up, though, come up straight. Come up out of
You
extension.
mean like
Yeah,
here?
back into external rotation and then back down. Yeah, you should feel that light up in that hip socket. And the airplane is a similar exercise.
Is the airplane just this guy?
Yeah,
That?
yeah, internal. Yeah, but I put my hands on the counter or something, and I just stabilized my torso. I'm not really worried about balance here. I'm really more worried about, this is the airplane. I'm pulling it up. Jen, what are you feeling?
Let me do the airplane thing. Right.
Yeah, I don't have a picture of me with my leg up, but I'm trying to, it's almost a cousin of this exercise, but the extra part is the external rotation we're getting. So they usually show the arms out like an airplane, and you're just rotating the pelvis in and out in a vertically loaded position. But it's hard to balance here. So I put my hands on a table, on the chair in front of you, Deb. I mean, any of you guys, all of you.
Okay.
Instead of flapping around, put your hands on the table and stabilize yourself. Balance.
Okay.
Lift the leg up.
If my right foot is forward, right?
Yeah. So
Uh,
as my leg's up, I'm rotating my hip down and then rotating my hip up. So I'm trying to feel that pelvis rolling inside my hip socket.
What?
Okay. So,
Oh,
Yeah,
you're
Stay there,
that's really
stay there as far externally as you can get. Now drop in as deep as you can get in that hip socket and then go back out of it. Yeah, but rotate from the hip socket out of it. Yes, good. Now rotate deep into it. Good. Now try to minimize how much you're doing that in the shoulders and back, just the pelvis, the hip socket. And then you can change the position stage by going a little more vertical, a little more horizontal. Find the deepest part of that stretch that you're feeling, of that movement.
Yeah, when I go in, that's where I get the big pinch right in my.
Yeah. You probably have
hip.
a lot of glute tightness.
Yes, that's true.
Yeah, well, it's deep six, so this should really put a stretch in that hip socket of yours. Yep, dump that hip. Yeah.
Yeah, way easier on my left.
Yeah, you should feel a big stretch in your piriformis when you do this one. But we're not necessarily trying to really stretch anything here. We're trying to activate those lateral stabilizers, because this is where you don't have stability. You're relying on that deep six, which then forces the femur head forward and up into the the acetabular impingement zone.
Say that again, Mike. That's interesting.
So when we think about the joints of the shoulder or hip, we talk about a ball and socket that roll around, right? But it's rolling and gliding. So as a joint rolls one way, it glides the other. And typically in the shoulder and in the hip, we have tight posterior capsules that cause the femur, the heads of the femur and the humerus to translate forward as the muscles move them. So they don't have that posterior glide. And that's why a lot of stuff like the deep six external rotators of our hip become overactive because of weakness of our lateral hips and glutes. And now they restrict that posterior gliding motion so the glute doesn't pull the femur into place. And that's where we get this upward motion of the acetabulum in the socket causing impingement.
Okay, so because that's where the femur goes forward, and so Stacia, when you were there, I could see it the best.
Yeah, especially with hip flexor activation and tightening them and all that hip strengthening them. You've got to get rid. Most people, and I told Deb this, we can throw a blanket over this and cover most people with this. And I share this with my therapists. I work with these physical therapists, and they all agree with me that most people have weak abs, weak glutes, and weak abductors. And that combination results in strategies all across the body. Deb's strategies in her torso. We saw it through the assessment. You can see the beginning of it when we go through it in the assessment. Right. But Deb's strategies in her torso, the weakness that she has below, that's why that RDL single leg touch, you should have lit you up on that left side. Should have been really hard.
Yeah, but it's interesting because but my right side is more unstable.
Well, again, doing it both times, and I wanted to see you do it and then do the assessment and see if open that leg up any better.
Well, I did it. So
okay, you did it on both sides, right? Did it feel the same, or was one side easier than harder? Let's look at the right leg first.
The right leg was harder, less stable.
Yeah, the right leg. Just let it go. Good. Now let's see the left side. That's a little bit better.
Yeah, it does look better, actually. It looks more even.
Yeah, that looks a ton better. It looks almost even. Deb, do a frog. Stay there. Do a frog. Go out. Static frog. I'd say they're pretty even.
That does look great.
Yeah.
That's really different. So I have a question.
But this isn't even where I would start with Deb. We would have added this in the third or fourth exercise. I only do 6 exercises, no more. Because I know we have to address ankle mobility, and I have to address her internal and external rotation factors. Those two are going to address most other things. Her instability, her strategy to remain upright and walk when you watch her gait pattern is all attributed to weakness in the pelvis, that lateral shift she gets on the left. And then when you watch her standing single leg stance, which is we're looking at stability, she relies on her upper thoracic back and her arms to stabilize herself. So her exercise program, this is where we're at now, right, Deb? Are we in agreement? Did you see what I saw through this, Deb, this assessment?
Yeah.
Okay, so we're in agreement with that. So what I have people do, and again, you guys didn't see this earlier, but what I have people do, Deb is going through my certification course now, and part of it, the second part of it, is to submit 2 case studies. she submitted a case study for her husband, and we went through the exact same dialogue as to what I saw, and oh, I didn't see that. And so Deb's actually probably a step above most people because she's already gone through one case study, and I think I opened her eyes to a lot of things to look at, right? Especially the lats as a big contributor to a static strategy. We'll call it just that all it is. The lats can be very synergistic dominant in stabilization. In fact, the lats primary function is what? The latissimus dorsi. Shoulder extension, right? Abduction, adduction, and shoulder extension. Wrong. The lats functional. I know, Dad. I'm just teasing you. The lats functional purpose is lumbar stability through its lumbar sacral fascial connection. It's a strong stabilizer of the lumbar sacral fascia. And so we rely on that as a strategy. Think about an upside down Christmas tree or a telephone pole, right? You don't put guide wires straight down, you put them out. Well, if you flip the body upside down, it's an upside down guide wire. The lats come from the center point upward. So the further they come up, the more stability they're going to add, right? And that's why Deb's arms start to externally rotate and pull, because that external rotation is going to engage the lat and tighten it to stabilize us. And she locks into that posture, which is why she doesn't get what we call thoracic separation either in her torso. Cool. Does that make sense? So these are all strategies. We recognize tight lats. So let's stretch the shit out of them. But that's the wrong thing. We have to go after the weakness. Right now, we found that her hip has a big mobility restriction on that left. We just fixed it. Through fixing it, we also improved some stability. So it would be really interesting to see her do 3 sets of 10 with a decent amount of weight and then have her walk and see if we get that same gait pattern and see what kind of stability we're getting. So this program that she wrote up, this is her assessment form. You guys see it?
Yep.
So again, it's a lot of writing and stuff like that. It's kind of like I used Egoscue stuff because I was a student of him. So I just like to reference what she sees in her posture, and all the things that we talked about are making sense. But I just wanted, what I asked them to do is based on what you understand about the assessments, and then we have a 4-stage protocol for writing a program. It's based on a systematic approach. Mitigate pain, put them in a position where they're out of pain. Then we start working. But we know a lot already from the assessment where to start. And then what is our protocol? Why do we start? What is the rationale for starting the program? Where do we want to start? And so I don't know if you wrote that. You didn't write your exercise program.
Yeah, it's in the other page.
Well, I didn't get that page.
I sent you 2 emails. So you should have a second one that has the other 2.
I got this page, Deb.
Yeah, it was the second one in that. I think.
I only got I got this one.
1. Yeah, 2. You didn't get that. You didn't get this one? You want me to?
No, I didn't get that one.
Oh. Interesting.
Unless you sent it after. Let me just double check. I think I only got 2 emails from you.
Right. I got one of them I sent 2.
Oh, that's why. Well, okay, never mind. I didn't
The
see
last one I sent 2, which had that in it.
So Stacia and Jen, this is the approach. So now we've gone through this assessment, and we spent a lot of time in the beginning, and I think you guys, it's just the first 30 minutes because we get right into the assessment. Sure. So watch it, because I'll illustrate some things that I pointed out, and you'll see as we talk about these things in the movement pattern assessment how they all relate back to the static posture, and it starts making more sense, and it gives us a more narrow. I told Deb this before. It's kind of like a sales funnel. Static posture is up here. It has a lot of things, and then we have to start getting a little more refined to the assessment to find that underlying culprit. And I really truly believe it's that left hip on her. And if we can stabilize it, get it to move better, which we did in one exercise, and we get better ankle mobility, I guarantee that her upper body is going to change 100%. Because the next question I'm going to have with Deb is, have you focused on this before?
No.
What was your thoracic? It was a lot of thoracic stuff.
Well, okay. So initially, I was in a lot of pain, and to work, I could not work my upper body for a long time. And I would be back and forth with being able to actually work my upper body. And a lot of times when I do my upper body, it aggravates my neck. So I mostly work with the lower body. And I knew that, but at some point, the upper body is also an issue, right? But it's like going after that without changing the lower is just like.
But the upper body is an issue. The upper body is a strategy. If you were a baseball, oh, there's a second page. If you were a baseball player or a tennis player or someone that was upper body dominant because of, like me, that was a pull-up king, then I would say we've got some inherent strength compensations in upper back. Yours is a strategy for lack of stability somewhere. And it's coming from that left hip. I definitely from the left hip, but I guarantee there's also what we call a lack of disassociation of the torso and pelvis. And that's part of that lat connection. Like Jen was mentioning the connection of the pelvis to the torso. I don't think of it as, I think of it more in the fascial lines, the fascial planes. You guys familiar with those, like the cross patterns? The posterior and anterior have to connect. And what I was sharing with Deb before and some other people was, this is a new set of videos I'm going to be producing soon that go a little more into detail. Some of the assessments I showed you guys, that Faber and the internal rotation one. And then there's a whole series. I'm going to add a whole section in here called stability testing, because stability testing it really helps us see where the lack of stability is. And it really comes down to, is it an anterior compartment problem, posterior compartment, or a rotary compartment problem? And I'm working with some people in physical therapy right now. I'm working side by side with physical therapists who are going a direction, and I bring something up to them that I saw, and they said, interesting. And they try an exercise, like, wow. And I have two of the therapists I've been working with are starting to use my exercises in the same, with the same understanding of why I gave it to these clients, and they're starting to see it. They knew all this stuff. They just don't see it like I do. And so the stability testing that I'm going to put together, it helps us kind of even get further down that sales funnel. And it really should be as simple as screen. It shouldn't take us all day. The more versed you get in, this way Deb and I spend time on these case studies, so she gets more familiar with how you look at things and how quickly you can assess it and draw the conclusions with them, right?
Hey, Mike, I'm really happy you're bringing up fascial lines, because that's actually, that's kind of what you guys too, maybe Stacia and Deb, that's what I see when people, I'm like, wow, that's just this big sheet, that's what I try to explain to people. So what I really appreciate immediately is just the languaging around underneath the sheet, so to speak. So we have these, right? Because your joints have to rotate and everything else. Is that kind of...
Yeah, it's
if
all.
they don't, then you're...
I have a colleague at work that's all he talks about is fascia. We had a big discussion about it today, and this
Oh, that's cool.
the connection and the information that's sent to him. Here's her second sheet. But yeah, I don't get into I don't get into too depth of the fascial stuff. I just look at the muscular connection to it. Okay, so this is the last part of the certification of the CTS2 that we go over. Now that we've kind of looked at the assessment, we've kind of driven down to where the most significant components are, and then we compare my notes that we just went through with Deb with her notes. I would have already done this, and I already would have had my assessment ready to go. It probably would have taken us a half hour, maybe an hour total, but I did a full assessment so you guys could see it. Need to address ankle mobility, dead on. Address restrictions and asymmetry standing. Is that right, Deb? Standing, rotation. Okay, good. That's what we talked about. Include spinal stability. And what's this last one?
Lumbo-pelvic control, because I know that's...
And the number four is
joint
dissociation. Yeah.
Range of motion.
So this is essentially exactly what we need to work on. I would probably do all this in one exercise program. We probably would hit it, most of those in one. Reduce forward, reduce right.
That's more right. This is more
postural. Oh, that's postural.
Yeah.
Okay. Yeah,
which is kind of lines up in a way with
yeah.
that. It's just different.
So
Yeah.
active dorsiflexion. What is that?
Active ankle dorsiflexion. That's the one that, because I need to improve my ankle
So this is
dorsiflexion.
calf raises?
That's the one. It's you're like in a
I don't know it, so you have
half,
to tell me.
yeah, it's your exercise.
I don't have an exercise called active ankle dorsiflexion.
Well, maybe it's called something else. Let me show you.
I, I really stick to like wall drops, active straight leg raise, or
Half kneeling.
I showed you this. This is like an ankle mobilization drill.
Yeah,
Okay, yeah. Okay, good. Cats and dogs, and then so what I would want. I know why she's going after ankle dorsiflexion. I don't care if this was a wall drop, but I'd rather see
Yeah, wall drop
somebody
doesn't work
do.
for me.
I'd rather see somebody doing a activation exercise versus static. So I would rather see someone doing calf raises, 3-position toe raises, calf raises, loaded calf raises, just for the strength, because weakness in the calf muscle can result in stiffness too. And someone that has excessive dorsiflexion is actually more prone to, Deb,
Yeah,
prone to what? Someone that has excessive dorsiflexion is prone to what?
excessive dorsiflexion.
So don't say the answer. But when we did her husband's case study, she told me one thing. She's like, oh, he has an Achilles tendon rupture.
Achilles.
And I
Yeah.
said, did he play basketball? She's like, yeah. How did you know? And I said, because that was the number one sport where we see Achilles tendon ruptures, and it has to do with excessive ankle dorsiflexion. And she said, I said, let me guess, he's got really good. She's like, oh, he's beyond 4 inches, like 5-6 inches. I said, I knew it. And so I'd rather see him doing a lot of calf raises to stiffen that calf tightness. He needs it. People that have tight calves could have stiffness just due to lack of strength and stability too. Remember, if we're not strong in an end range, we're going to go back to a midpoint range where we're stable as a strategy. So any type of dorsiflexion activation or just stretching as a part of the beginning of the program, because that's what we identified as the number one problem, right, Deb? In the protocol.
Yeah. So are you saying that you would not do that one?
No, I said sure. Anything that's going to give us a dorsiflexion. I like more active ankle. So maybe that, and then throw in like some calf raises, right? We want to keep this under 6 exercises. So those are 2 big ones. And so what I would do is this.
Cool. Yeah.
If I want to decide between one of the 2, and if it was me, I would do that exercise and test it after. If I don't see an improvement in dorsiflexion, I'm not going to waste your time on it. I should see a relatively quick improvement if we're doing a static stretch. If it doesn't improve ankle dorsiflexion immediately, then it's kind of a waste. We're not hitting the right thing. So I'd rather see active like heel raises and then go test it. If we get improved range of motion, then we've got strength through an improved range of motion. And the rest of the program that we're going to build is going to build on that new dorsiflexion position, right?
Yep.
So whatever one you want to do, test it right after, because that was the number one reason you put it in there. You better be testing it. Don't waste your time. We're not guessing here. Did this work or not? We'll see in a week. Now I'm going to see right now, like I did with that RDL I did with you. I know that's a good exercise for you. So guess what? If you don't have RDLs in here, you're missing the point.
I don't have it in there, but I do know.
But that's the question I was going to ask. After the RDL, I was wondering if Deb, you had better ankle flexion, dorsiflexion.
Oh, thank.
Yeah, I mean, I would test it, definitely.
Yeah, like it just seems like that would make sense. That's the whole, yeah.
Why would that make sense? Because you're really not.
Okay, because she had to rotate on her tib fib while she did that balancing, and so you would the whole line.
Again, this is a great concept, Jen. That ankle restriction she has, she always says she's unstable. She doesn't feel stable. So if we create more stability, that calf could say, okay, thank you, and let you go. We don't know unless we test it. But we have a test to try it.
Got it.
Right? And now I know I don't have to waste time. If we get better ankle mobility from that, then let's not even do it a calf raise. Right? I want 3 exercises that I can throw at someone and make them go, wow, I feel this.
Yeah, I feel it. Deb, how
I
was
can
that?
see it and I can feel it. And I can tell her, we didn't even have to go watch her. Deb, did you do your ankle mobility any better? Yes or no? Deb, do you feel better toe touching? Yes or no? It's an objective measure. Now that your client has a way to say, yeah, I can tell a big difference with this. How's your posture, Deb? Is it any better? Right?
Yeah, right.
Okay.
Well,
So
and
was there any noticeable
well,
difference?
I did not test it since I've been doing a lot of sitting here, and
Yeah, it would have been better
like
to
before,
test her
I don't know what
after.
it was,
But it'd be
honestly.
better to test her after, before and after the program, right? And so good point. That's a really good
Oh,
point.
okay, so I can tell you that the ankle, I didn't retest the ankle mobility, but I can tell you that the active ankle dorsiflexion improved my rotation ability, both in my lower body, all up my body. It made it more equal and increased it.
Well, also, that exercise that you're doing, the active ankle dorsiflexion, I don't think I call it that.
Yeah, you might not. It's a
I know I don't.
ankle mobility something.
Okay.
It's not active. It's ankle mobility something. Sorry. Ankle
Well,
mobility.
anyway, there's also a lot going on with other parts of your body in that one that's different than just a pure ankle stretch. So if the fact that you felt different in other aspects, what would be interesting is to do that exercise and see if it improved, to Jen's point, your internal external rotation. Because if it is, then we don't have to do RDLs. But RDLs are a big strengthening component. So I need that in there because it's a bigger strength component than a stretching component. I'll give anyone RDLs to do all day long because it's primarily the weakest part of the body. And most people don't load the glute eccentrically like that exercise does. And that's the primary function of the glute, is eccentric deceleration of the limb as you hit the ground. All right, so good, Deb. We've kind of looked at that. Cats and dogs, you wanted to do it for flexion extension, bilateral, the spine, pelvis, flexion. I like cats and dogs for a lot of things. It gives us that disassociation. It's also a way to test for disassociation. Does the pelvis and torso move as a unit, or is it stuck? That's fine. But
And again, after I tried cats and dogs, then I did the whatever you call it, ankle mobility thing.
Yeah.
And cats and dogs was definitely way better after. It's like I am more symmetrical in my.
But that movement that you're doing, this active ankle dorsiflexion, it's also taking your hips through a big range of motion.
Yeah.
So that's not a bad thing.
Right.
And that's why it's probably a great exercise for you. I want to follow it up with more strengthening components. So cats and dogs, sure. The hip crossover, you're doing it for that external rotation component. But if we're getting a significant amount with RDL, let's just keep it one less exercise. Unless it's the RDL someone has a tough time stabilizing, balancing, or there's pain, then we have to regress them to maybe a hip crossover, right?
Right.
There's other things you can do for external rotation. I haven't even taught you that yet. Active hip openers. Again, another internal external rotation component. I'd pick one and test it. If it's working, we don't have to do 10 of them.
Okay.
Right? So we can keep this, because the number one complaint that most people have is clients don't do their home exercises. They're too long. They're not challenging. So make it a challenging program that they see results with pretty quickly, or they're not going to come back. If they do, they're an ideal client. You give them anything you want, but you want to be an effective client so you can get them in and out and get someone else in, right?
Right.
Totally. So quadruped leg lifts. What are those? Just the back.
Yeah, those are like it seems like they're really strengthening the glutes.
Sure.
In those, and also if you get the shoulder blades down together and don't just let everything hang, it seems like it stabilizes your core or whatever.
I like it.
So after those,
well, here's the thing. You're going to improve. We're looking to improve external rotation. If we've got it, then let's go after the next part of that, which is hip extension, right? Yeah. And the strength stability aspect. So I like that you're going into strength stability stuff at the end here, right? You've got a couple mobility stuff, and then we go right into strength. The RDL should be in there somewhere. I'd argue
Where would you put it?
active hip openers. I'd argue whether you need hip crossover and active open. I think they're somewhat. I like the hip crossover for you better than the active hip openers because you don't really have internal rotation issues. I don't know. That's a good call. It's a tough one between the two. I'd definitely put a rotational in there. I'd probably use the active hip openers. I like activation exercises, even though hip crossover is an activation. I like the mobility of the active hip openers. And what active hip openers are, you guys, is
It's like knee drops, only you press the knees towards the floor instead of just relax them.
okay. So you guys know those.
Okay.
I like this is what I call them. So as I'm going into external rotation on one, I'm driving the other one internal rotation, and then opening the hip up and going from external to external, and actively trying to pull myself into both. So yeah, then we go into more of a loaded position. I love hip hinge, wide stance hip hinges, because when you go in that wide stance and you start going into external rotation, you're also taking that hip through a large range. You're creating stability and kneeling ankle squeeze presses. That's kind of the new exercise at the clinic. Everyone saw me doing it with a client, and now the PTs are doing it. We're almost done here.
Yeah, I decided not to do the active leg raises yet for
Active
me.
straight leg raises.
I've been doing them some, but they're just so hard. And
Yeah,
I'm
there's
like,
a weakness in the lower pelvis. So this is what I call kneeling ankle squeeze press downs. It's a way to activate the abs and glutes, the lower cross syndrome, the Jardin's lower cross syndrome, which is tight hip flexors, tight erectors, weak abs, weak glutes. So this is a way to kind of, someone with back pain, I don't care who they are, try this exercise on them first. And you'll probably see that back pain ease up quite a bit because we're getting the glutes to engage, getting the abs to engage. Like I said, the blanket statement, I say that lightly, that most people can be affected by just strengthening their abs, strengthening their glutes, and then the rotational component. But that's what Deb's talking about, that exercise. I like it, Deb. I would test it after and see where you're at, right? Your biggest thing is I'd love to see your gait pattern after doing a program like this. I definitely would want to increase the level of demand for you because you don't have your compensations we found and everything all points to weakness. And again, with the shingles being a neurological thing, there's that component of it too. So you don't have enough pain to warrant. I'd get you loaded and start functionally training as much as we can, right? And just get more demand. I'd add resistance to it. So I'd add an RDL in here. I'd take out one of the two, hip crossover, active hip. We are going to take out the active dorsiflexion. Yeah, you can throw cats and dogs. The cats and dogs are like a primer, I call them. Unless someone really has, huh?
I want to know what you would give me, not what I would give me.
All right. You guys, if you want, talk amongst yourselves. I got to write this up.
You guys, I'm so sorry. I have to go, but I will absolutely follow up on the beginning of it. And thank you so much. It's nice to meet your faces here.
Yes.
And
Yeah,
Mike,
you too, Jen. I hope this was helpful and at least showing some depth of what this program's about.
I'm really excited to see this. I mean, to look at the rest of it. And then just, if you don't mind, is it okay to text you?
Yeah, text me, call me, whatever.
Okay.
Email.
All right. And it'd be fun to talk to you and Deb and Stacia at some point. I'd love to do that. I'm in California.
Thank you for jumping on, and feel free to reach out to me anytime.
Okay, thank you.
Yeah.
Okay. Bye, you guys. Sorry.
If you want, Mike, I can do that, whatever the exercises are, and we can do a follow-up if you want. But
I'm going to do a couple
a lot of work,
quick.
Or I could just report back. How's it going, Stacia?
Do you guys know each other?
Good.
Yeah,
yes, we've been on calls like this before.
Oh.
A while back, I think.
A long time ago, yeah. I
Yeah,
haven't been as active, yeah, with
for a bit.
all
Well, this seems really interesting, you
this.
know,
It is.
and I love the idea of reduced number of exercises. I do work with a lot of older folks, so loading people with, weight and stuff like that. I like it. I guess you just start depending on their ability, but I do like it.
Mm.
I'm excited to just see a little bit more about uh, like how this comes out and
Yeah.
a little more from Mike, but I want to let him think. So,
Yeah.
how
You
long
know,
have you been looking into this, Deb?
goodness.
Involved?
Then I can't remember when I have a thing here since December that I wrote down when I started doing. So I think it was somewhere in November, December, but it's been kind of slow because whatever. You can go through it at your own pace, but uh yeah, it I love the exercises and the tweaks and the focus on, especially, and all the Egoscue stuff. And people have had look at me. Nobody's ever came down to my left hip as being an issue.
Well, you could see it if you guys know gait analysis when you watch it. That was the first thing I saw, right?
No,
We didn't even do the assessment.
I had a few people, and this has been years now, and they looked at my gait and they're just like the other therapist in our group, and they're just like, I don't know what's going on.
Well, that's the first thing I saw on your gait, right?
What's that?
That's the first thing I saw on your gait.
Yeah, yeah. So, well, and when I was like 2, apparently I had a severe leg break. I don't know which leg, and I don't know if it was upper or lower or anything. All I know is it was very severe. The bone went through and everything, whatever. And my sister said I ran different after that, my leg like flopped out. So my guess is it might have been my left because that tends to go valgus, which might make my either that or what the thing is the left goes valgus, more valgus, the right goes more internal. So either one could kind of make your leg right, your bottom leg go out. But
Yeah, you found a new strategy to get around, and
yeah, I mean, I figured out how to,
I mean, this is I feel like we've gotten down this funnel pretty far. Is there more stuff going on? Is there shingle stuff going on? Probably, but we've got some better answers. We've got some results just from a quick exercise that showed us a significant change. So I think we're on the right track, right? It just makes it more and more refined that the more information we can provide for the assessment. And the stronger we are understanding the assessments and what to look for, the faster that happens, right?
Yeah, and just a little bit ago, I felt a release in my left erectors. It went so, which is good. Those are the erectors that were like.
Well, again, part of your erectors are part of your lats too that are.
It's my left side that, like.
But your erectors are, probably engaged because your lats are so damn strong, too. They're all working together. We needed. I've got that. I've got that. I've got that. I've got that.
I'll be right back.
Stacey, you have any questions for me? Thoughts?
Well, while you're in the middle of writing stuff.
Yeah, I'm at 4. I don't really. This is a good.
Yeah, basically, if I could get better at finding the root, I look at posture, I do some functional tests, I do gait, but finding the root more quickly and giving fewer exercises would be great. And I think the Egoscue helped me a lot when I had all my aches and pains. But it wasn't until I started doing foundation training and then getting back into some weights and things like that that I went up another level.
Yeah.
I still have issues. My spine is a little scoliotic at the bottom.
Yeah, but you got to start
working
really on
for my clients.
You got to start working on rotational patterns. I can tell you that much right now.
Well, I'll tell you, are you familiar with foundation training?
No, But I think you mentioned
So
it. May have looked it up.
I'm a huge fan of it, but one of the best exercises when I feel a whole lot better is this thing he calls a woodpecker. So you got your right foot back, left foot forward, or vice versa. And you get your lats engaged, but you're just doing a rotation. So my right hip goes
Yeah,
down
yeah.
and in,
Yeah, that's like
back
a cousin
neutral,
of that
down and in.
airplane.
Yeah.
Yeah.
So like, that has helped me a lot. And you're right in saying when I do the rotational stuff, it's better. But it's interesting with Egoscue a lot of times, or just in various things I've taken classes with people. They're like, look, when you have scoliosis, you want to avoid rotation, which I don't do it because it makes me feel much better to get
Yeah.
exercises where I'm getting that. And same in the gym. And
Well, again,
you know,
it's
all kinds
depending
of
on where
things.
you're getting rotation from.
Yes.
Are you
Is it
getting
hitting the
rotation
right
from a
spot?
compensatory pattern or from the right authentic movement with the hip?
Yeah. Mm-hmm.
Because
So
rotation on the hip, rotation on the thoracic spine isn't going to affect anything. It's where it's needed, not the lumbar spine.
yep. Yep.
I'm stuck on one exercise. I'm at 4, Deb,
Ah,
but the
okay.
basic I would have you start with active straight leg raises. Oh, I know what I'm going to have you
When
do.
I was saying, I'm not entirely, I need to see what the outcome is. What do I need to test to see is better after doing that? Because it's
I
very
would test,
hard for me.
huh?
They're very hard for me, and I need to know what am I,
What is the
what,
exercise for? So this is for Stacia's intensive purposes, learning, understanding this. And the protocol for corrective exercise, the 4 phases of it is first is kind of mitigating pain, right? Don't put someone in pain, try to keep them out of pain. Second with that is the lumbar pelvic control, stability, core stability. We have to have proximal control for distal mobility. So we need lumbar pelvic control. You wrote it up here, Deb. You want to establish lumbar pelvic control, address restrictions, asymmetries. Oh, you put it third. So I would switch these. We need to make sure we have enough stability in the lumbar pelvic region, spinal control, so that we can get true, authentic movement of the hip sockets. Because that's what we're going after next. We're going to go after the ankle mobility right after that. But I put it first because I wanted to do an asymmetrical exercise before we got into ankle dorsiflexion. Because if there is a contribution to weakness of your pelvis that causes your ankles to be tight, like Jen was mentioning, then it may help. So I would say it's synonymous to some ankle mobility stuff. You can test ankle mobility and a toe touch. The biggest one is test your toe touch. Also test your backward bend. Your backward bend should improve after doing that one because we're getting more lumbar pelvic control, which may give you more trust in bending that back. Plus, we're taking away the necessity of your lats to be engaged, so you should be able to get a little more shoulder flexion. That's what I would be testing with it.
And
after
single leg raises, is that where you're on your back and you're just opposite leg, or what?
Yeah.
Okay.
I'm sorry.
Go ahead.
I was just asking after active straight leg raises. Those are the things you would test.
I would test. Yeah, I wouldn't be the first one. Be ankle mobility. The first would be toe touch. Second would be backward bend. You should see an improvement in those because we're creating stability, lumbar pelvic control, which is synonymous with the backward bend and toe touch. The more stability and control you have, the better you can do it. This is the active straight leg raise. Start with both legs up, pressing. You got to create stability. So I have people press in. You can have them hold a weight over their head or a band, a weight over their head, something to get lumbar stability. And then we're just doing active straight leg raises. Boom, boom, boom. This is also a test for what, Deb?
Interesting.
Hamstring extensibility.
Hamstring extensibility.
Yeah, if someone says, I can't touch my toes, I have tight hamstrings, someone can't touch their toes, I lay them on the ground and just test their straight leg raise. If they can get past their ankle joint, past the knee, then mid-thigh, we know they have acceptable ankle range or hamstring flexibility. It shows them that they don't have tight hamstrings. It shows us that they have weakness. Then that way we improve stability. We go after And then what else did we notice in Deb? Deb, what else did we notice in your static posture? You have a very forward lumbar extension, very weak anterior compartment. So that active straight leg raise is also focusing on anterior components of strength, right? The pec, the lat, well, the lat's part of it, but the pec, the abs, the hip flexors, anterior stability, which should give us some better backward bend. That's why I have it at first. Then I'd go after calf raises, standing calf raises. I do that. Maybe you want to do the other one, see which one you like better. RDLs, single leg rotations. And this is where I was kind of stuck. I would probably even, this is just to balance things out. I like your idea of a hip hinge wide stance. Weighted, I do weighted here, almost like good mornings. I'd hold a kettlebell or dumbbell and do weighted ones just to get more glute activation out of it. And I'd leave you with that, 4 exercises. You should see a significant improvement in those patterns of movement out of those exercises. And we focused on ankle mobility, core stability, internal external rotation, and glute engagement in those 4. That I'd like to see what you look like after that. 4 exercises. That's enough for someone like Stacia to say, I could do 4.
Yeah.
And these are demanding exercises. They're more demanding than what you had. What you put down wasn't bad, Deb, but there's some filler in there.
Okay.
There's some filler. There's some redundancy, which I don't think we need redundancy, unless you're willing to do it. If you want to add those to this, I'd put this at the end of your list, and do your first 7, and then add 4 more, which is 11 exercises. Or compare the two. Do yours, see how you feel, and then do mine and see how you feel.
All right.
Yeah,
like
do that, and then let us know. Me too.
Yeah, I'd like to see that.
Okay.
Does that make sense, Stacey? Even though you didn't see the whole assessment?
Yeah, I didn't, but I was listening in on the phone call. I was just driving. So, and my phone, the video wouldn't come on, which is probably good since I was driving. But anyway, I did listen in, and I will go back and watch it. And I'm sure it'll make a lot of sense.
Yeah. Listen, Deb, when Deb and I did this the first time with her husband, she's like, wait, what? Wait, what? Right? It was really confusing to you. You got the concept, but we kept going over it and over it and over it. This is why I wanted her on the call, because now she's getting a lot more comfortable with the assessment. And even though she was like, but it's making a lot of sense to you versus the first time going through this, right?
Yeah, it's definitely starting to, I'm learning more each time.
Yeah, which is why I have you guys do 2 case studies. I review them like this with each person. And by then you're really starting to click in to gear.
And so give me just a rundown of what this looks like. So, if I went through this certification, what's the average time and what's the time spent?
Well, you literally will be devoting your life to me. I'm just kidding. Jesus.
I'll be seeing clients. No, just kidding.
No. So how long did it take? Well, Deb, you waited. Where's my assessment?
You can't gauge by me. I'm very slow in learning. I'm a slow reader, and it takes me a long time to go through things. So you can't. I couldn't even tell you. I took
this is it here, Stace.
Yeah.
This is the actual certification course. There's 1, 2, 3, 4 modules, 5, 6, 7, 8, 9, 10. There's like, I don't remember how many modules there are, but each one has an ebook to it, like about pain. There's a couple pages. We talk about pain and kind of some nuances of it. Gross Anatomy is a pretty good anatomy book. I go into functional anatomy, kind of differentiate them. So this is at your own pace. How long would it take you? You can go through this honestly in a weekend, because every one of the questions in the CTS1 course, I tell you which questions 48 through 50 are in this module. So you just go in verbatim and you can find the answers right there. So if you want to go through CTS1 and get certified and say, I did it, you'll get it done in a weekend. Do you want to learn it and understand it? That might take you a little bit longer to comprehend. I do have videos related to the, I haven't added a lot of videos yet explain this. That's my next goal, is to start doing that. But I have a lot of assessment forms. That's where Deb got all this stuff. I don't even know where they are. Here's one assessment form. Here's the ankle mobility. There's some videos on showing you on how to do it. And then there's also an additional resources. I don't know if you watch these, Deb, but this is where I go into. This is additional ankle mobility knowledge. This is an hour presentation on just ankle mobility and the nuances of ankle mobility. And then you start tying them all together. So each pattern, 6 patterns, has an additional 6 hours of videos to go into understanding the dynamics of what I'm talking about in 2 seconds with Deb, which is why she's like, I got to go back and watch those videos. Because you'll get very versed on it the more you do it, the more you do it, the more you do it. Everything will start making sense because you're going to start seeing the same things happen. You're going to start recognizing patterns of how people move, and you'll be able to relate it to these patterns of movement.
All right, I gotta run in a minute. But
CTS2, you don't have you basically once you're done with these assessments, you take the test. CTS2, I'm pretty sure in the course in the exam, I think I don't remember, Deb, if you remember it or not, but I think I have information in the CTS2 in the other part. Maybe I don't, but anyway, what I'm getting at is there's different phases that we'll go through. So there's the modules on corrective exercise system, basically what that process is of how do we decide which exercises to put in place and which ones to choose, why I chose what I did. There's a systematic approach to it. I knew from her assessments and everything she told me, we can progress her a little bit faster than just static back, right? I don't have to start her there, but I can't start her with splits like Bulgarian lunge split squats. So I got to find a happy medium that challenges her, to makes her want to come back and do it and feel a difference versus some cats and dogs that I think are great for everyone, but is it challenging enough and stimulating enough for her? Probably not. And that's why I chose these exercises. And it's based on the protocols, part 1, phase 1, phase 2, and so forth. And then once you're done with this, you submit the 2 case studies to me like Deb's doing today. You and I will sit down personally and go through them. And you'll be like, Mike, I don't know if I'm seeing this right. Will you help me see this? I don't see this. And I just walk you through it. I hold your hand. That's what's taken, Deb. We've done this for about a month now, right? Yeah. And that's why I said, why don't you get on and do a case study with us, a review? We're already at 2 hours, a little over that. But sometimes it takes that long. It won't take that long. It took us about an hour. Once I have all the information, we'll look at it, talk about it, go back and do your next one, review some of the stuff, see if it makes sense for the next case study, and then it starts clicking a little bit closer. So it depends on what your time frame is. There are no time limits. Nothing expires.
Sure.
You don't have to retake anything.
Okay.
Yeah.
Well, it's good. I got to run, but I will definitely be in touch.
Awesome. Good stuff.
All right. Good seeing you, Deb.
It's great to meet you. Thanks for
meeting
jumping
you,
on
Mike.
and staying with us.
Yep, you got it.
Have a
good
great
evening.
one.
See ya.
I have a quick question.
Yes,
Did you
ma'am.
stop recording, or it doesn't matter?
No, I'll stop.
The calf raises, is that like 3 position toe raises, or is that like the calf raises that you have?
Yeah,
Those
whatever you
take
want.
me
3 position toe.
forever.
Sorry?
The calf raises that you have in your system, it seems like it takes me forever to do them. I know, maybe I'm doing them wrong. 5 sets of 5 reps going back and forth. It's like,
no. Those are not those. No, I just do 3 position toe raises, but I just do them straight. I don't do them out and in. I just do them straight.
Okay.
I just focus on dorsiflexion up on my big toe, down into dorsiflexion. Plantar flexion up on my big toe, down. I'll do a single leg. I'll rep out some single legs on each side. I just try to get my calves I want to feel my calves. I want to feel that deep stretch, and I want to feel like I got some work in my calves. Nothing special about it.
Okay. All right. So just like the 3 position toe raises straight. Okay.
Yeah, that's all I do.
Well, I'll try it out and retest stuff and see where it's at and let you know.
Yeah. This was good, right? I think your assessment was great as far as your protocol, your approach, your thought process. Now it's just kind of figuring out with your client or yourself, is there redundancy in the program? Am I doing 2 things or 3 things too many times? Or can I get away with just one that has the biggest impact to move on to the next thing, right?
Right. Well, and I love that, but I don't okay, so you have with the assessment, you have exercise sequences you could do, right?
Right.
Well, it's kind of like, well, because you figured those out in general and whatever, but like here you gave me four that aren't really, two
Yeah,
of them.
they're very similar. So this program, even though it's four, I think three of these relatively are in that ankle mobility pattern program. I know active straight leg raises are. I know the calf raises aren't, but the calf stretches, wall drop, or the standing calf stretches that you're talking about. And I'm
Yep.
almost positive hip hinges are in there.
Hip hinge, they are, I
Yeah,
believe.
and the RDL, there's something else that supplements the RDL. I don't remember what it was, but there is.
Okay.
But
Anyway,
again,
it just that's the tough part, right? For me is okay, the assessments are great and
so
seeing
just break it down. I want to, like you did, your rationale, you said it perfectly in your rationale. You just need to reverse this part. You have to
yeah,
reverse this part. You
yeah, I'm
need to
still
address ankle mobility, great. So do it, whatever you
right.
can. Second was address restrictions and asymmetries, standing rotation, meaning you want to go after those hips. But we need, in the phases of corrective, now we're building a program, the exercise
Okay,
program.
so question, the reason I put that in that order is we did the assessments and I
Oh,
picked
you're
out,
doing it based on the assessment protocol. Yeah.
yeah. So my question is, where in this, I'm
So
still
you kind
not,
of blended the two here.
I'm still not sure if I'm the corrective strategy list, if I'm fully understanding all that. So where in this corrective strategy does ankle mobility and standing rotation fall? Is that
Yeah, great. So
spread out or
in which one? What?
me? Okay. So if you were to put, you said put spinal
Active straight leg
stability
raise first,
and lumbopelvic control first. Where
because that's the part of the that's phase two, or basically the beginning of corrective exercise approach.
right. So
Right.
the
So in
standing,
order to get distal mobility, ankle or hip, we need to get lumbar pelvic control first.
okay. So ankle mobility and standing rotation fall in the joint dissociation range of motion movement pattern.
Yes.
Okay.
After course of all even yeah, and then once you get to that part, and I think I even have it in there. Once you get to the joint disassociation stuff, then we use the mobility pattern assessment to kind of prioritize what's more important, right? But I always say ankle mobility starts the process.
Yep.
But we got to have some control. I don't know if
Yep.
that ankle mobility is a result of poor control of above. So at least let's ensure we have some control through some stabilization exercises, like active straight leg raises.
Right. Okay. All right. Well, I'm getting there.
You're very well. Again, your posture told us a lot about this. Your very anterior, posterior chain tightness. Your calves, your back, your lats, your shoulders. Your
Yeah.
anterior compartment is very weak. That's why you're so far forward. So we want to start with some
Totally agree. And it's
anterior
gotten
bias
like,
exercises. Stabilize you, rebalance it, see if the ankle improves. Most likely it's not going to be huge, whereas a calf raise is going to make a bigger difference. Then move into the RDL and hip hinge wide stance.
okay.
You can add more, a couple extras at the end there, like a squat or a lunge, just something to kind of add more demand to the new patterns. I just wanted to make it four quick, fast ones to see you have an improvement in the pattern.
Okay. Yeah, I'll
Right?
try that. See how it goes and let you know.
But this is good. This is you're in the right on the right track, and the your thought process as to why you did this makes sense because you wanted to do this and this, but you understood the concept. So that's what all I care about.
Yep.
That's great.
Okay.
It's awesome.
Great. Thanks.
It's really
Appreciate
good.
it. Hopefully a bunch of people
Yeah,
check it out.
I hope so. Well, it's a 2 hour,
Yeah.
2.5 hours. So let me stop
Yep.
sharing.
This is
Everyone,
not-
thanks. That was our assessment with Deb. Deb, thanks for your time on that. Let me just
Yeah.
stop sharing here now, or how do we do it?
Probably click on recording where it
No,
says record.
I can't get the other screen open. You know how they have, where is it?
Multiple
Oh, here it
screens.
is. Stop sharing
Oh, there you go.
and stop recording.